So overall, the clinical importance of the sex hormone binding globulin, which is also known as the TEBG, testosterone estradiol binding globulin, that it binds to testosterone, but not only to testosterone, it also binds to the dihydrotestosterone, to DHT, and it also binds to estradiol. So the levels of SHBG are highly influenced by the nutritional status, growth hormone, and prolactin, which reduce SHBG concentration. It also acts as a buffer for testosterone, and it also protects testosterone from hepatic clearance, because testosterone itself is a very short-living molecule. And once the molecule of testosterone is free, it's not bound to albumin or sex hormone binding globulin, and it's free circulating in the bloodstream, its relative lifespan is counted by minutes. 3 minutes, 5-7 minutes maximum. Low SHBG levels promote faster conversion of androstenedione to testosterone. Alcoholics are known to have a higher SHBG due to the SHBG being more prone to providing estrogenic effects, and also to the possible hepatic effects where it also exerts pro-estrogenic amplification. And that's why individuals with a primary biliary cirrhosis usually have a much higher, very high SHBG levels. And alcoholics overall, because of the SHBG, are also prone to the fast conversion of the testosterone to the estradiol. So another clinical significance of the SHBG is that the SHBG level changes produce more dramatic changes on the both free and albumin-bound testosterone than changes in the total testosterone numbers. And there is a difference in men and women in terms of the SHBG. In women, in females, 80% of the SHBG is vacant, while in men, only 45% of the SHBG is vacant. Normal range of the SHBG is from 10 to 70 nanomole per liter. As we mentioned, can be increased or reduced. Slide 37. SHBG increase can be achieved by natural or synthetic estrogens, by thyroid hormones, by anticonvulsants, by rifampicin, by clomid, tamoxifen. This is very important because clomid and tamoxifen are included in a treatment protocols that we're going to talk later. Also dexamethasone, progesterone, and HCG. So all this increases SHBG. What reduces SHBG are the drugs with androgenic or progestogenic activity, including natural synthetic androgens, synthetic gestagens, except progesterone itself, and many anabolic steroids, such as the trenbolone, masterolone, exandrolone, stanozolol, specifically. So mostly all of the oral steroids and halotestin and all, they tremendously crash SHBG levels. And also proviron as well. Proviron, one of the functions of the proviron is to increase free testosterone level, and that is usually achieved via it releases the testosterone molecule from the binding with the protein. And we have mentioned free androgen index, FAI. Slide 38 illustrates how it's calculated. It's a ratio of a total testosterone number divided by the figures of the SHBG times 100. And that's how you derive FAI, free androgen index. So let's make a quick summary of the endocrinological control of the entire male function. And I have that on the slides 39 and 40. Let's go through that really quick. Testosterone, I'm going to call it T from here onward, significantly contributes to the regulation of male sexual desire. Testosterone treatment can improve libido in hypogonadal men, especially those whose total T numbers are 12 nanomole per liter and below. T regulates penile development and growth in early life, but not after puberty. T targets molecular pathways involved in the physiology of erection, including the nitric oxide and CGMP. And cavernous smooth muscle cells turn over. It's very important, and in the module 2, I will demonstrate, shortly before the module 2, in this module, I'll demonstrate you how exactly. The decrease in the circulating testosterone levels is associated with a decrease in erectile function. DHT, dihydrotestosterone, exerts similar but less effects compared to the testosterone on the erectile function, although treatment with DHT and its analog, such as a masterolone, is not recommended, cannot be recommended as an alternative to the testosterone replacement therapy in any hypogonadal or the eugonadal man. No way. DHEA and DHEA sulfate is not involved in the regulation of male erectile function at all. Prolactin does not play a direct role in regulation of the male erectile function, but treating hyperprolactinemia might have indirect positive effects on arousal and